a big welcome to our April webinar. Sorry, I'm still adjusting to us being in April. We are very excited that you are joining us this evening. And this webinar is brought to you in association with the University of the Witwatersrand and the South African Society for Hand Therapists. So tonight's topic is brachial plexus injuries, and we're very excited to have a speaker joining us all the way from Mexico. Thank you, Rosa Rodriguez, for joining us. I will introduce her to you guys in a second. Our contact details are on the next slide. Please feel free to reach out to us if you have any questions. But for now, it's time to start our webinar. So I'm going to stop sharing and introduce our speaker. So Rosa Rodriguez, other than being one of Open Hand Therapy Initiative's biggest fans on Instagram, where we connected, she also has a bachelor's degree as a physical therapist and a specialization in OT and hand therapy from the University of Southern California. She is a certified dermofunctional therapist and a university professor for the hand therapy fellow in Mexico. She has plenty of other certifications and studies from Mexico, the US, and more recently from Spain. She is the vice president of ATMMX, which I'm not going to pronounce the proper name, but it's the equivalent in English would be the Mexican Association for Hand Therapists. And she's also international delegate for ATMMX at the International Federation for Society of Hand Therapists. So welcome, Rosa. We're so excited to share your knowledge with us this evening. You're welcome to share your screen and get going as soon as you're ready.
Thank you so much. Great presentation. Thank you. So let me share my screen and you let me know if it's sharing properly.
That's perfect. Yeah.
Okay, so my name is Rosa. I'm from Mexico, the north from Mexico. And today we're going to talk about brachial plexus injuries, which is my experience. I have been learning from brachial plexus since 2016. That was my first approach. And since then, I started the search and the learning and the study a little bit more about this type of injuries. So it gets to be a very difficult injury and a very difficult situation when you get to have this type of patients, where I'm going to try to explain what we do here where I live, in team with the medical staff. So let's get to start. Okay, first to say that this will be to analyze the importance for the appropriate evaluation of the patient and the appropriate individual treatment for this type of injuries. This type of injuries is important because this makes an impact in our social, economic, and mental and physical health for our patients. So what we do here, I have a little bit of statistics. This is from Grupo Mielina here in Mexico. There is a group of medical staff that does the brachial plexus surgeries. So they have this type of statistics that said that from every 100 brachial plexus injuries patients, 70 of those patients can recover just with the appropriate physical therapy. And after 2020, from the 2 million births, they say they had a statistic of 8,000. And from those 8,000, 2,500 needed a surgery. And well, here the traumatic brachial plexus injury, it's due to motorcycle trauma is the 75%. And there will be a 10% approach that will never get a diagnosis of brachial plexus injury. It can be an adult or a kid. And The last time we were in Guadalajara with the doctors, they were, talking about the numbers. So here in Mexico, there are not as many doctors for brachial plexus injury, like microsurgery specialists. So they say they will have 78 patients per doctor here in Mexico per year. So it's something that needs to um grow in Mexico as the doctors and as the physical therapists, because there are plenty of many patients that need to be treated and they are not being treated. Okay, so we are going to start to see the brachial plexus injury from the perspective that if you have a patient that actually needs the surgery, you need to start with the patient with a pre-operative plan. Is very important because you need to learn that these type of patients sometimes will not come in an early stage of the injury. Okay, some of those patients are chronic patients. They already come with deformity. They already come with muscle atrophy. So you need to get to have a plan once is diagnosed and once the doctor has a surgical plan. Okay, here is very important. What we try to teach our physical therapists and OTs that get involved in our fellow, we try to teach the importance of the communication with the doctors. Okay, you cannot work an upper limb, a brachial plexus, a hand injury without getting to know what the doctor did to the patient or what the diagnosis is or what the studies tells about the injury. So the first thing is, what does the doctor expect based on the examination? And he expects from a rehabilitation for the surgery. The second thing is, how much time do we have after before the surgery? How much time? Sometimes here what we do is they give us sometimes like a month to 3 months before planning the surgery on the patient, so we can start working with the patient, we can start the learning process about the injury, and we can start getting to have a better joints and a better hand before the surgery. Another aspect that is very important is the patient environment, the caregiver environment. And if the patient and the family gets to understand the injury, because sometimes they tell you like, oh yeah, this patient has a total brachial plexus, and then he goes to surgery and the patient comes to therapy and they tell you like, in 2 weeks I'm going to be ready, and it's like, no, this patient doesn't even know what the injury is. Okay, so here is when we get to have the mental, the physical, the habits aspect, which is very important. And I think the nutritionist and the psychology, it's very important during this process and the follow-up with the patients, because it's a very complex injury that they get to have and that they get to understand. And they are, like going through a loss. So they need to really understand what is happening to their body for them to have a better recovery. Okay? So what we get to do on the preoperative plan, the goal is to preserve a good hand, the range of motions complete, because like I said, sometimes patients get to come to the therapy with a very bad hand, like stiffness and all of that. So we get to work to have a good hand. Even though the hand is the last thing that we are going to recover, you need to have a good hand, because you don't get to have the patient after the surgery and then start working on it, because it's already, like losing time on the treatment. Okay. Another important thing is to keep the external rotation of the shoulder. That's very important, and to avoid pectoral contractile of the muscle. Also very important, the muscle and the postural hygiene of the patient, because sometimes these kind of patients, in the when they try to move the hand, the shoulder, everything, they get to have like very bad back compensation. So we have to work on that too. And of course, avoid the joint stiffness, talking to from the hand, the fingers, the carpal, the elbow, and the shoulder. Okay, that's a pre-operative plan. And how are we going to work on that? Okay, we are going to work on all of this with electrotherapy, going into the mother end plate of the muscle for the end plate maintenance of the muscle. We are going to do a nerve pathway stimulation, depending on where we're working. If we're working on a patient that has a radial injury, or it has a cubital injury, we're going to work with electrotherapy in all the pathway. We are going to avoid the deformity using night splint and day functional splint as the patient needed, depending on the type of injury. We're also going to start working motion with electrotherapy in the passive and active assistive way. It's very important that the patient doesn't forgets about what the movement is, because when the brain doesn't work that way, that's the way we have mirror therapy. When the brain doesn't have that stimulation, the brain forgets about what that movement is. So it's very important to have the stimulation from the central nervous system to work with the extremity, and of course the sensitive techniques. And then we are going to talk a little bit more about what we do in a preoperative. These are videos of some of our patients that needs the surgery. So we get to work with them, we get to teach them, and to try to them to use the limb as much as they can. We get to put some splints and to teach them how to use the splint. If it's only a day functional splint, how he's going to be using it. And if it's a night rest splint, at what time and from what time to what time he's going to use it. Okay, then what we would have in the post-operative, or sometimes when we don't have a patient that needs that needs the surgery, and the doctor decide the patient only needs therapy. Sometimes when the doctor take that decision, here what we do is that we give the patient in between 3 months to 6 months at the most, for the doctor to take the decision if the patient is going or not to surgery. Okay, so well, when the patient goes to surgery, like I said, it's very important to have a communication with our doctor. If it's possible, go to the surgery room, ask the doctor if you're allowed to go to the surgery room to see the patient, to see the surgery. Because, once you are in the surgery room, you get to see all the trauma the patients uh, go through, and your focus change absolutely everything, because then you will have a scar in the leg if they get to have a graft. And then you will have a scrub in the thoracic area if they take the graft from there. And the edema and the recover is different when the patient goes through all this trauma in the surgery. So if you have the opportunity to talk to your doctor and ask them to be there, to take pictures, to learn, please do it. Don't miss that opportunity. I think it's very important to get involved and to learn what a patient is going through, okay? So the thing we are going to work with the doctor is what type of surgery the patient end up doing, because before the surgery, doctor has a plan, like a surgery plan, depending on the studies the patient have. But once the doctor get to open the patient and explore the brachial plexus, sometimes the surgery plan is totally different from what they expected to be. Okay, so at the end of the surgery, you need to learn what they did, if the patient has graft, where the graft was taken, because there's different grafts and there's different like type of recovery depending on what nerve graft the patient has, okay? If the patient has transfer, muscle transfers, tendon transfers, if it was only a C7 nerve transfer, okay? And what indications the doctor has, what precautions the doctor has, or if the doctor has some limits for the therapy, okay? Sometimes, like we get to see in the picture, patients get to be immobilized totally, the arm in their body, so you cannot work in that type of patient, the brachial plexus injury right now. But if the patient has surgery for the graft on the leg, you can start working with the leg, okay? Or if the patient only, if you get the opportunity to be in the surgery and you get the opportunity to do the splinting for the patient. So sometimes you have this type of splint and you get to teach the parent when he's going to use the splint, when he's going to take it out for the exercises and all that, okay? Well, if you don't know, this is a picture of Dr. Clifton, Dr. Orlando, and Dr. Gilbert, Gilbert. Um, I call them my masters, okay? They're very, very amazing doctors in this field. This is a C7 contralateral transfer of a nerve, and they're doing this with a graft, okay? With a laboratory graft of nerve, okay? So the recovery will be different from another kind of nerve transfer. So that's why we need to learn what the doctor is doing. If you get to see all the trauma the patient is going through, they're opening the both sides of the neck, they're pulling, they had to take off the clavicle, they have to open the clavicle. So you need to understand what the patient is going through in the surgery, because it's not an easy surgery, okay? It's not easy what they go through. I get to have patients, that they wake up from the surgery and they are like, I feel like the train, pass over me. And I'm like, probably, okay, probably might feel that way because it gets to feel like all the trauma they go through, it's very difficult, okay? And you get to really learn. You get to really learn from these surgeries, the work they do, the patients they take to do all these type of surgeries. It's amazing. Okay, this is a contralateral C7, and it was a very amazing surgery, okay? It was performed by Dr. Clifton, Orlando, and Alain Gilbert. Okay, so what are my goals after the surgery, after the patient goes through all of this? We wait till the second week to start treating the upper limb or the brachial plexus injury. But like I said, if your patient has a graft taken on the legs or in another side that it's available to treat, you can start treating that after the surgery, okay? If not, we wait till the second week when the doctor take off all the casts and everything to check the patient, and he takes the decision if you can start the therapy right now or if you wait a couple of more weeks. But sometimes this is the time when we start working. If the graft is good, if the edema is going down properly and all that. So that's when we start, okay? We have some patients that wait a little bit longer, but that depends on the surgeon, okay? If the surgeon tells you, you know, we need to wait for 6 weeks, okay, after 6 weeks, then you start working with your patient. Okay, so what are my goals when we start with this type of patients? After the surgery, okay, we have to do the management of all the edema and the inflammation the patient is going through. It's very important that the edema and the inflammation, it's managed and it's controlled, because the more inflammation you have, the more time the surgery will take to recover, okay? Sensibility. It's very important to know that something you don't feel is something you don't move. Something you don't feel is something you don't get to use, okay? So if patient take a lack of plenty of time, you know, with the sensibility, it doesn't matter if you're working the movement of the hand, if the patient don't get to have a good sensibility when this happen, is not going to use the limb properly, okay? So we're going to see if the patient needs a splint, if it's for the day, if it's for the night, how is going to use it, and if the patient needs, if the doctor needs you to do it like a progressive splint, okay? We're going to start working with the scar tissue treatment. It's very important because the fibrosis this type of patients gets to do, it's there, okay? And it's very, very, very much of a scar tissue that they get to have, and that can lead to a bad recovery of the graft, of the transfer, more if we're talking about tendons, okay? So we're going to start with the passive range of motion, taking care of the angles that we get to work. That's what you need to talk with the doctor. How can you move the patient if you have unlimited range of motions, of if you have to do it in a certain way or with a limit of angle, okay? We keep working with the postural hygiene, and here is the most important part of the brachial plexus injury, the caregiver or the family training, okay? The more you take time to educate your family member that is going to take care of the patient, or the caregiver that is going to take care of the patient, the better results you will have, okay? we become teachers for them, for the patient, and for the caregiver. Because sometimes we want all the patients to have the same money, the same economy, and to come to therapy daily, but that doesn't happen here. Sometimes we get to have patients that they get the surgery. We see the patients the next day and we don't get to see them in months, okay? Because they travel to get the surgery and they don't live here, or they don't have the money to do this therapy. So you need to learn how to explain the family and the caregiver what to do, when to do it, and how he's going to do it in the patient. Okay, that's very, very, I think this is the most important part of everything. Okay. Okay, after we go from the surgery, and this plan can work to um for the for the patients that didn't go through a surgery, okay? So we're going to work with a specific electrotherapy, talking about maybe motor spots, if he had a muscle transfer, to re-educate that transfer, or talking about a specific part of the nerve. So we are going to do it more specific in this time of the rehab, okay? Sometimes I get, like I say, the caregiver training. Sometimes I get to tell my patients to buy themselves a electrotherapy tents, and I teach them how to use them. I teach them where he's going to put the electrodes. I teach them how many times a day we're going to be using it. I put like with a mark, I mark the spots where we're going to put it. I take pictures and I do the plan, the therapy plan based on that. So the patient can have electrostimulation daily, more than one time a day, okay? Because let's remember, the nerves, it's electricity, and the muscle moves with electricity, okay? Because we need to understand that after the surgery, the patient is not going to have recovery or muscle movement till the maybe 4 month, 6 month, okay? So we need to understand that we are doing all this with a process and hoping the patient gets to recover after that time, after the surgery or after the diagnosis, okay? We're going to keep the splint by need if the patient still has, I don't know, a pendulum hand and it needs daily for a functional movement. So we're going to do a splinting by need. We need to start working too with mirror therapy. That's very important for the central nervous system. It's, a biofeedback. That's a biofeedback that we get to trick the brain that it's using the other hand. It's very important to start with occupational therapy, functional re-education, depending on like I said, if the patient has a muscle transfer, a tendon transfer, we get to re-educate what the muscle does in the new spot, okay? Body image feedback, and again, caregiver training, very important. There's a little bit of mirror therapy. We use this, I forgot about the name of the white, it's talco in Spanish, but I forgot the name. If someone knows it, please let me know. But we use it because it's easier for the hand to move around the area when you use it. And it's also like a sensitive stimulation. And that's how we work with the mirror therapy. Yeah, Shulk. That's it. That's the name. Or talc powder, yes. That's it, yeah. The one we use for the babies, that you don't get to use it anymore, but yeah, that one. And like I said, that helps us to avoid like the friction of the table, so the patient can move a little bit easier, and it's also like a sensitive training. Okay, so why is the complexity of the brachial plexus injury? Something I have learned from the years I have getting to know this type of patients. I started in 2016, and it was a big surprise for me because the first time here in my city in Torreon, Coahuila, they have the fellow of microsurgery of the nerve. So doctors from another countries come here and do the fellow and operate patients. So those patients, I get to see them and I get to learn from them. Okay, so the first time I got this first interaction with a brachial plexus injury was in 2016, and I remember I saw the page of the surgery, and it says EPL transfer to EZR, and I was like, what is this? And it said like long thoracic nerve to radial nerve, and I was like, what is this? What are you talking about? I didn't saw this in school. And that's when I started to get involved and to learn more about brachial plexus, because I said like, this is not normal. This is very interesting. So I get to start learning, and the complexity that I have learned is that you might have 10 total brachial plexus injuries, like the same diagnosis, but you will never have the same evolution in each patient, okay? I would love to have like a specific protocol so you can work with that, but that doesn't work with brachial plexus injuries because you will never have the same evolution after the surgery or after the diagnose, because brachial plexus injury depends a lot of different factors. And I think this is very important. The economic factor, I think it's crucial because sometimes patients don't get to have a brachial plexus injury surgery because they don't have the money to pay for that type of surgery. It's a very specific, a special surgery, and they don't have the money to pay it. Okay. I think another factor that is very important, it's a family support. When these patients don't have the family support or the caregiver support, the patient doesn't evolution like we might plan to evolution, that we might want. So it's a very important factor that all the family and the patient and the therapy and the doctor are in one single page. That's very, very important for me. Another factor is the mental health. Every time I get to have a patient with the brachial plexus injuries diagnosed, the first thing I ask is if they are taking psychological help, because they have a lost. For how long? We don't know. We don't know. And they have a lost. And most of these patients get to be men in a very productive age. So, and it's the family that has the economy and the work and the everything, and is the dad, you know. So mental health is very important, is very important for me, because when you have a depressed patient, and I will send you biography, and one of those biography, it talks about the depression, the substances that goes through the brain that doesn't help in a physical therapy recovery. Okay, that makes it a little bit longer. So that's a fact. A patient that is depressed will not recover as we might want to. Okay, so mental health is very important for me. The nutrition is very important for me, because the nutritionist can help us with food that can help us to heal, you know, that food that is not inflammatory, food that is adequate for the nerve, for the muscle, and all that, you know, in a very perfect you know, in a very perfect image of what brachial plexus injuries would be in a team, I would put all this, okay? Because patients needs all this. They need a doctor. They need a physical therapist. They need an OT. They need a nutritionist. And they need a psychologist. That would be in a perfect page, okay? In our country, we get to do what we have, okay? We get to work with what we have, and this is what I have learned and what I have give to my patients, okay? And it's very important for me. And I put it on the table and I tell them, this injury is this. It's when I start to educate my patient. And I tell them the importance of have help, okay? Another people and another specialist help. And I get to talk to the doctor too, and to educate the doctor too about what the patient might need during this process, because the doctor get to see the patients for the diagnosis, after the surgery, for the surgery, after the surgery, to see what is going through. And the thing is that they see it five times in 6 months. And you as a therapy get to see the patient like mostly of the time. In this type of injuries, you get to be part of the patient because it takes a lot of time, okay? I have had patients for 2 years, you know, after a brachial plexus injury. So you are the one that goes along with the patient. So you get to understand more the needs of that patient and the therapy that is going to go through. Okay. So tobacco, it's it will delay the process of recovery. Alcohol will cause more inflammation and edema. And of course, the drug use is a substance. It, depending on the substance they're using, is going to also delay the recovery. Okay, here we also tell the patients that they need to slow down the drinking coffee and drinking Coke, because of the colorant that is in those drinks. Okay, so, and very important too, like I said, the understanding of the injury. I get to have my patient and ask them like plenty of times if they get to understand what they have. Okay, because it's very, very like it's something that still happens. The patient came and tell me, okay, but I'm going to be ready for next month because I have a golf tournament. And I'm like, no, you're not going to be ready for next month or 2 months or 3 months. Okay, so that's the part we get to have, also the difficult one to put it on earth. Okay, like you are the one that is going to tell them the bad news about that type of injury. So when you get to make them understand fully, you are going to be a great therapist. Because if you don't, and if you promise the patients things that you can do, you are going to be a bad therapist. Okay, so understanding the good rehabilitations comes from the good educations for the patient and for the caregiver to ensure an effective home therapy for faster result and for lower result and for lower cost. You know, economy is very important here in our country because, like I said, sometimes we get to see the patient once and they come back in 6 months or they come back in 3 months. So the good educations and the better you effort to do as an educator for the patient and for the caregiver will lead us to a better recovery of the brachial plexus injury. Okay? Well, thank you. I want to say thanks to Erica, Nicola, Christy. Thank you very much for this opportunity. Hopefully, these presentations give you a lot of doubts, okay? Because doubt will lead you to do research and lead you to learn more and to have, you know, the yeah, the need to learn a little bit more, because this is something, like I said, something I have learned from for what I have here. I live in Torreon, Coahuila. It's the north of Mexico, and we don't get to have a lot of sophisticated things as we want to, but we are working on that. So thank you. If you have any question?
So much, Rosa. I really enjoyed your presentation. I think we can relate a lot to similar challenges. I think some of your challenges of not having enough doctors to do surgery, not having patients come back as much as you would like. Those are definitely things that I think we can relate to in our settings as well.
Yeah.
Yeah, there hasn't been a huge amount of questions in the chat, so I just want to encourage the participants to please add some more questions. I
Okay.
know in the pre-webinar, in the sign-ups, there was a few questions about Erb's palsy. So the babies that are just born. Can you maybe just speak to like your management of Erb's palsy as the kind of the first question?
Okay. Well, here's something that we tried to implement in the hospital where we were doing practice in social service. We ask the babies area if we get to, you know, go to see the babies to do like a physical examination, because sometimes brachial plexus, the mom doesn't know nothing about it, and these babies don't get to have a early diagnosis because of that. So we ask this area to go there and to examine the babies to see if we get to see like the sign of the earth palsy and to see like the limbs and to have like a pre-diagnose. We don't get to diagnose here in Mexico as a physical therapist. You need to have the diagnose from the doctor, but then we will have, like the opportunity to tell the mom, like, you need to start working with the baby, start the external rotation to keep the movement of the shoulder and to keep an eye on the baby and to see if the air palsy start to recover by itself, or if it's needed for the patient, the baby, to go to a doctor and to see if they need a surgery.
Well, thank you. There was also a request in the chat. If you, by any chance, have a case that you could share with us, what was done immediately after therapy, and kind of what was the recovery time for a specific patient, if you have one that comes to mind.
Okay, like one of the babies, I might say, I don't know which one. Okay, I might say like the baby that has the C7 contralateral is still in recovery. It's been 6 months since the surgery. So the baby is still in recovery and is starting to show movement. Okay. The thing is that babies recover faster than adults, okay? You get to see a baby, and after 6 months, 8 months of the surgery, they are already like in the last stage of the recovery because they're babies. Their body is built to start, producing everything and to recover, and they are full of collagen and full of everything. In difference of the adult, the biography tells you that the the adult will recover 1 millimeter per day, okay? But like I said, we will have factors that will affect this recovery and the time of the recovery. So if I get to talk about the kids will recover very fast, very, very fast. That's the first thing I tell to the parents, like, you don't get to worry a lot because the baby will recover very fast. And if you see one of the pictures, I had a patient, a big patient, an adult patient with a splint with external rotation. Well, that patient, that was a difficult one because he lives like 6 hours from where I live. So that patient, I get to see it every 2 months, and the recovery is not as fast as I wanted because a factor we have with this patient is his weight, okay? His arm and the weight of the arm is too heavy for the surgery and for the graft. So this is like the importance of having a nutritionist and having the understanding of the patient that if he does not lose weight, the recovery will not happen like the way we plan to do.
Well, now all the questions are flooding into the chat.
Mm.
Um, would you be able to share anything about chronic pain management? Someone shared a story in the chat of someone opting to have the limb amputated because of ongoing pain. So yeah, can you speak a bit to that?
Okay. Yes, we start treating pain like when the pain is still like in a control time lapse. I personally have the time of 6 weeks to work with pain, only with physical therapy, electrotherapy, physical like ice, heat, and all that. If after the 6 weeks I don't have a significant evolution of the pain, I transfer the patient to the pain clinic because that is something I don't get to work with. Okay. Maybe the patient needs now another type of treatment. That's very important to know that sometimes physical therapy will not do everything for the patient. Okay. And it's something you get to talk to your patient and to make it clear that you are going to start working with that. But if the therapy doesn't work, you're going to transfer the patient to the pain area, okay, to the pain treatment area. So he gets to have doctors that work with him, again, with the lack of time. And if the medication doesn't work, they transfer the patient to the surgeon so he can see if it's available to do the pain surgery, like the nerve, cutting the nerve, you know, if it's available, if the pain is very chronical, and if he already do the physical therapy, already do the pain management, they take this type of decisions to cut the nerve that is causing the pain.
Sure. Yeah, thanks. Another question was, does surgery ever undo your pre-op treatment? So
The
do you ever
what?
have someone who's so if someone's making progress pre-surgery and then they have the surgery, do you see them like regress or get worse again after
Yes,
surgery?
yes,
Okay.
yes, I have those patients. Sometimes I get to talk to the doctor and to show him with facts what's the recovery of the patients, with evidence what the patient is recovery. And sometimes the doctor gets to understand and to tell me, okay, I will give you 3 more months, but that's it. Like sometimes 6 months, 8 months, it's the last of the time the patient will recover. So we will have I will have that time, talk to the doctor and tell him, give me another 3 months and we will see what we can recover in 3 months. And after maybe those 6 months, patient doesn't need the surgery, or maybe patient needs the surgery but needs a different one than the first one planned, because he already recovered a lot of things, and he might need like two more things to do. So, and yes, we have patients that goes to the physical therapist, and I have a patient actually, like, that happens that after the surgery he started having chronic pain. Okay. And it was something very difficult to treat because he was amazing with the therapy, and then he had the surgery, he started having chronic pain, he stopped moving the limb, he started doing anything because everything was very painful. Okay, so we lost a lot of muscle, we lost a lot of movement, we start having a stiffness. And that's the time when I told the doctor, like, this is not working, something is bad. Okay, something is happening with this patient, that the recovery is not going as I planned. And he had to go again through surgery, and to do another type of intervention because of the pain. For him, they took the surgical plan to cut the nerve that was causing the pain, because he was already with morphine, and nothing happened. And that's very heavy, because the patient tells you, like, I'm a zombie, I cannot even work, I cannot do anything because of the painkiller meds. So yes, you will always struggle, not always, but you will struggle with this type of patients, and you need to understand that is normal, because you're working with nerves. And like I said, you will never have one patient similar to another. Never.
Kind of on the same note of that question, what is the kind of prognosis post-surgery? So do you see patients fully recovering, and how long does that take after surgery?
Okay. I think I didn't mention this. Okay. The very important thing that I have seen with brachial plexus injuries is that I get to let the patient know that he will never be the same as he was. Okay. That limb will never be the same as he was after before the surgery or before the trauma, because sometimes they expect to have a full 100% recovery of everything, and that will never happen. Okay, you might not have the 100% recovery of the upper limb, but you might have 100% functional limb. Okay, that's kind of different to understand, that you might not have a full range of motion with the patient, but you have 100% functional patient. I don't know if the point is clear.
Yeah, that makes sense. Thanks. So there was a question also, maybe just one more in terms of time, but after 5 years, if you have a patient who's not improving, um, what would you still see them? How would you structure your intervention if you've got someone after such a long time that's just not making any more progress?
Sometimes that depends on the patient. I still have patients that was like one of the patients I have, he plays paddle, uh like tennis, something like that, paddle. So he had a brachial plexus injury in 2019, and I still get to see them like once in a while because of him. He's the one that tells me, I want to go there for you to check if I'm okay, because I feel like I'm losing strain, or I have a contracture or something like that. But it's more up to the patients, because sometimes when you have like 2 years, I give them 2 years for fully recover everything that we're going to recover. Okay. I tell them that we have like the lack of time is 2 years. If in those 2 years we recover like 90% of the injury, maybe that's it. Okay. Maybe we'll not have more thing to do. And that's when you have to be clear with the patient, because sometimes some patients take the decisions to take another surgery. Okay. Because they tell you like, you know what? I want more. So they talk to the surgeon and they ask the surgeon what else can be done. So that's when we have, this type of patients. But sometimes after 2 years, the recovery will get slower, and you are not going to get a lot of changes.
Thanks, Rose. I think that time frame is very helpful, and I think what I appreciated about your presentation was how you really emphasized patient education and getting patients to have a realistic idea of what the journey is going to be like. So we've gotten to 8:30. I'm just going to share my screen again to close off. Yeah, there's our contact details again. Yeah, so thank you for joining us. You will receive a link to the Zoom recording. The webinar will be made available on YouTube, and our next webinar will be on the 6th of May, and it will be on complex regional pain syndrome. So I hope you will join us for those. The registration will be made available in the next couple of weeks as well. Just a reminder to please follow us on our social media platforms. And if you would like to join our mailing list, you can scan this QR code. and then you'll get the webinar adverts directly in your mailbox as they become available. So thank you again, Rosa. Thank you so much for taking your time to share with us. We really enjoy the opportunity to collaborate across countries. So yeah, thank you again. And thank you everybody for attending. Have a good evening.
Have a good evening. Thank you for the opportunity and hopefully doing a little bit more.